Hello everybody. Today we are going to talk about retention and relapse. Okay, at the end of this lecture, the student should be able to define what is retention and relapse, identify the etiology of retention and relapse, outline the methods of retention, classify the type of retention devices we use, and explain the theories of retention. Okay, now there are three concepts that we have to understand concerning retention and relapse. One is retention, the other is concept of stability, and the relapse. Okay, now let's look at retention. What is retention? Now, retention is the final phase of orthodontic treatment which aims to maintain or retain the teeth in their corrected positions after completion of active tooth movement. Now, without retention, various factors will cause the teeth to move back or relapse to their earlier pre-treatment positions. So why do we need retention? Now, it has been shown that after movement of the teeth, the periodontal fibers and gingival fibers are very slow to reorganize and readapt to the new position of the teeth. This is especially so in gingival fibers, which can take up to 232 days uh, for the supracrestal fibers to reorganize and readapt to the new position. Now, if the final occlusion is in an unstable position, then there will be a relapse tendency, and continuation of the growth of the jaws after completion of treatment also contributes to relapse. Now, there are various schools of retention, and these schools explain philosophies that explain factors that determine the stability of the final occlusal positions of the teeth after completion of active movement of teeth. Now, the first school of retention is the occlusion school, which says that there must be a proper occlusion established after treatment to ensure that the corrected position of the dentition is stable. Now, the second school of retention is the apical base school, in which it states that the apical base is the most important factor in the maintenance of stability, and especially the intercanine and intermolar width must not be altered from the original width, and Nance stated that arch length cannot be increased significantly, meaning any arch expansion is bound to relapse. Now, the third school of retention is the mandibular incisor school, which states that the mandibular incisors must be kept upright over basal bone to maximize stability. Now, the causes of relapse can be divided into four big groups. That is the periodontal and gingival factors, soft tissue factors, occlusal factors, and finally growth factors. Let's have a look at the periodontal ligaments. Okay, now when teeth are moved, the principal periodontal fibers and the supracrestal gingival fibers are stretched. Now, if these stretched fibers were to contract after completion of treatment, it will lead to the relapse of the position of the teeth. Now, the principal periodontal fibers usually reorganize in about 4 weeks, but the supracrestal gingival fibers reorganize in a much longer time, and even studies have shown that even after 232 days they remain stretched. Okay, now bone adaptation. Now teeth that are recently have been moved into a new position are surrounded by lightly calcified osteoid bone, which is not stable yet. Now, during the retention period, the bony trabeculae gradually reverts to a normal architecture. In the immature bone, the trabecula runs parallel to the wrong axis of the tooth, and gradually as they mature, the trabeculae runs perpendicular to the long axis of the teeth. Okay, now growth related changes. Now, many skeletal problems usually worsen if there is continuation of the abnormal growth pattern with after completion of the treatment. This is especially in class 3s where you have continuing mandibular growth, which will overcome the effects of treatment. The other kind problems that will worsen with growth are a deep skeletal overbite and a skeletal open bite. Now, the other cause of relapse is if the original etiological factor, original cause of the malocclusion has not been corrected. So, at the time of examination and diagnosis, all probable etiological factors must be identified, and these factors must be removed or at least reduced in their severity. If not, correction will relapse. For example, a low frenal attachment that is not corrected will cause a reappearance of the midline diastema. Now, let's look at the role of third molars. Now, the third molars erupt between 18 to 21 years of age. It is frequently impacted or unerupted. Now, it is said that the pressure of the erupting third molars plus the mesial drift of the dentition causes late incisor crowding and relapse. Now, but this has not been shown to be true, and it is not proven. As we can see, some researchers have pointed out that even after the third molars have been surgically removed, the lower incisor crowding still worsens. And the other point is, even individuals with congenitally missing third molars still develop lower incisor crowding later in life. So the role of third molars in the cause of relapse is unproven. Now, the role of the occlusion. It is believed that a good intercuspation of the upper and lower teeth post-orthodontic treatment ensures the stability of the corrected dentition. Now, preferably the centric relation and the centric occlusion must be the same, or if at the most there should be no more than 1.5 to 2 millimeters slide from centric relation to centric occlusion. Now, relapse can also be caused by occlusal mannerisms such as clenching, grinding, nail biting, and lip biting. Now, other factors involved in relapse, okay, these also one is tooth size discrepancies. Now, Bolton said believes that there is an ideal ratio of the maxillary teeth to the mandibular teeth. Now he said that the mandibular 12 teeth, that is from the first molars to the first molars on the other side, it should be 91.5% of the maxillary first molar to the maxillary molar on the other side. Now the mandibular 6 teeth, he said, should be about 77.2% of the maxillary 6 teeth. Now if the maxillary teeth is relatively larger, so this tends to be compensated by a deeper overbite, a bigger overjet, or a combination of deep overbite and big overjet, crowding in the maxillary arch, and a class 3 tendency in the buccal occlusion. Now, if the mandibular teeth is relatively larger, this is compensated by an end-to-end class incisor relationship or a class 3 tendency. There tend to be a spaced maxillary arch and this crowding in the lower anterior segment. Now let's look at theorems of retention. There are 10 theorems of retention. Now this theorem describes the different philosophies regarding retention. Okay, the first theorem is that teeth that has been moved tend to return to their former position. Now it's shown that orthodontically moved teeth show a tendency to return to their original position, and this tendency is larger if the amount of movement is larger. Now the possible reasons for this tendency to relapse could be muscular forces, bone morphology, the transseptal fibers, and the positioning of teeth in relation to the apical base. The second theorem is the elimination of the causes of malocclusion will prevent recurrence. Now, as I have stated earlier, it is necessary to identify all possible causes of the malocclusion at the time of diagnosis and eliminate these causes if it is possible or reduce its severity. This is especially true for causes such as abnormal muscular forces arising from digit sucking, tongue thrusting, and other abnormal pressure habits. Now the third theorem is that malocclusion should be overcorrected. Now there is little evidence for effectiveness of overcorrection, but notwithstanding that, there are few examples where some operators do overcorrection. One is a deep bite overcorrection and finishing a class 2 diff1 to an edge-to-edge occlusion, so that the relapse tendency will bring it into a ideal class 1 occlusion. Now rotation can be overcorrected by a slight rotation in the opposite direction to the original rotation. Now fourth theorem of retention is proper occlusion is an important factor in holding the teeth in the corrected position. Now this is Fiedler has stated that an good occlusion, which means proper intercuspation, will ensure stability of the end result. Now, fifth theorem of retention is bone and adjacent tissues must be allowed to reorganize around newly positioned teeth. Now, during tooth movement, bone remodels as the tooth is moved, and the periodontal fibers are stretched when teeth is moved. Now, a sufficient duration of retention is needed so that the immature bone surrounding a newly moved teeth can mature, and also periodontal and gingival fibers are reorganized to the new position of the tooth. Now, the sixth theorem of retention is if the lower incisors are placed over basal bone, they are more likely to remain in a good alignment. Now, post-treatment stability increases when the lower incisors are placed upright over the basal bone. Now, here upright means the lower incisor is placed perpendicular to the mandibular plane or plus minus 5 degrees. Now, in growing patients, the mandibular anterior segment tends to exhibit a physiological migration pattern in a posterior direction. Thus, a slight lingual tilting of the lower incisors ensures less relapse since it's in the same direction as the physiological migration. But the difficulty arises in determining where the basal bone begins and ends. Now, seventh theorem of retention is corrections carried out during periods of growth are less likely to relapse. So this means that as much as possible, treatment should be instituted when the patient is young and actively growing, because this is because growth can only be influenced when the patient is growing. If once growth is complete, uh, it's difficult to achieve skeletal changes. Okay. Now, inhibition or alteration of growth direction using headgears, myofunctional appliances should be done during the growth period. So this also means that it is preferable to do interception which enables corrections to be done before excessive dental and morphological compensations occur in the dentition. And also, if in the situation where we are expanding the maxillary palatal suture to expand the maxillary arch, the immature sutures are more amenable to expansion. Okay, the eighth theorem of retention is the further the teeth have been moved, the more likelihood of relapse. Now, teeth moved a long distance are prone to relapse and also prone to root resorption. Therefore, interceptive measures are more appropriate so as to avoid extensive move of teeth later on. Now, the ninth theorem of retention is arch form, particularly mandibular arch form, cannot be altered permanently by appliance therapy. So, alteration of mandibular arch form is likely to relapse. So, as much as possible, mandibular intercanine and intermolar width should be maintained, and especially critical is the intercanine width. Now, the last theorem of retention is that many treated malocclusion require permanent retaining devices because some types of malocclusion are inherently unstable. Okay, and when they are unstable, they will need long-term or even permanent retention to hold the teeth in the position. An example of this is where a situation where the treated dentition is periodontally compromised, and in this situation permanent retention will be needed. Okay, so retainers are used to provide retention after treatment. Now, what are the ideal qualities of a retainer? A retainer should primarily be able to restrain each teeth from moving. It should, while restraining teeth from moving, it should also allow some amount of physiological tooth movement so as to allow a functional occlusion. Okay, and the appliance or whatever is used for retention should be self-cleaning and permit good oral hygiene measures. It should be sturdy and durable so that it is lasting, and it is should be inconspicuous because being inconspicuous, it will be more aesthetic and well accepted by the patient, and will also lead to better compliance. Now, the retainers can be broadly divided into two groups, which are the removable and fixed retainers. Now, let's look briefly at each of these. Okay, let's first have a look at removable retainers. Now, the Hawley retainer, which was introduced by Hawley in 1920, is a very commonly used retainer. It has three components. It has the retentive Adams clasp. It has a short passive labial bow, and it has an acrylic base material which acts as a connector and base for the other components. Okay, the Hawley retainer has a few advantages. It is easy to fabricate. It is simple in design. Good patient compliance due to the reduced bulk. It can be used either in the maxilla or mandible, and it can be modified because you can add things like bite planes into the acrylic plate. Now, the disadvantages are, of course, it's susceptible to fracture or loss. It can be difficult to insert if there's severe undercuts present in the premolar or molar region. Now, the Hawley retainers can be modified in many ways. Okay, one of the modification is to put a C clasp on the molars instead of a Adams clasp. Okay, now this is indicated if the occlusal contacts are very tight, as putting an Adams clasp in such a situation may cause occlusal interference. But the disadvantage is a C clasp is less retentive compared to a Adams clasp. Now, another modification of Hawley retainer is to put a occlusal rest. Okay, so occlusal rest is put instead of a Adams or a C clasp. Now, again, the indication is if the contacts are very tight, and to avoid occlusal interference from having occlusal arms arms of the Adams. Okay, again, the disadvantage is less retentive than Adams clasp. Okay, now the other modification is instead of a short labial bow from the canine to the canine, we can also put a long labial bow from the premolar to the premolar. Now, why would we want to do that? Because having the arm passing between the premolar canine and the premolar can cause premolar extraction space to reopen due to the wedging effect of the labial bow arm. And by using a long labial bow which passes behind the premolar, any residual extraction space between the canine and the premolar can be closed with the bow. Okay, now another modification with the labial bow of a Hawley retainer is to use a contoured labial bow. Now, a contoured labial bow is contoured to the labial surface of the anterior teeth. Now, this contouring of the labial bow can increase the retention of the appliance in the anterior segment. Okay, and it is also gives a better retention of the anterior teeth from relapse because the bow is closely adapted to the surface of the labial surfaces of the teeth. The disadvantage is it is more difficult to fabricate. Now, Another modification with a Hawley retainer is to replace the labial bow with a light elastic. So this light elastic stretches across the anterior teeth. Now the use of this elastic can help to close minor spaces in the anterior segment. But the disadvantage is the elastic is difficult to control. Now, the Hawley retainer can be modified by the incorporation of a bite plane. Now, for example, an anterior bite plane can be incorporated on the acrylic base plate, and this will help to retain the deep bite correction. Now, a back retainer was designed by PR Pack. The components of a back retainer is an extended labial bow, which extends till the last erupted molar and curves around it, and it's got an acrylic base material. So, the advantage of a back retainer is there's no crossover wires anywhere in the occlusion, so therefore there's less possibility of the extraction space opening and less occlusal interference. It can also be used where the molars are partially erupted, which is difficult to provide a good Adams clasp. But the disadvantage it is less retentive compared to a standard Hawley design. Now, the clip-on retainer, another type of removable retainer, it has a wire framework from the labial of the premolar to the premolar, and it recurves to lie on the lingual surfaces of the anterior teeth. And the wire on both the lingual side and the labial side are embedded in acrylic. Now, this is used to retain the lower anterior teeth. It is useful in situations where is unable to provide the appliance with full coverage up to the molars because of deep undercuts, which sometimes are found in adult dentitions. Okay, another removable retainer is the wrap-around retainer. Is same as the spring retainer, but it extends to all the teeth. Now, the Kessling tooth positioner was designed by Kessling in 1945. It covers all the clinical crowns of the upper and lower teeth and a small portion of the gingiva. It does not cover the interocclusal space. Is made from a thermoplastic rubber-like material. Now, the advantage of a Kessling tooth positioner is durable. There's no activation needed. It can be used as an active removable retainer during the final finishing stages. Now, the disadvantage is there's some speech difficulty due to the bulk, and the fabrication of the appliance requires a special apparatus. Okay, this another form of removable retainer which is now gaining in popularity is the vacuum form retainer, or also known as invisible or Osamu's retainer. Now it fully covers the clinical crowns and a portion of the gingiva. It's made from thin transparent thermoplastic material. Now the advantage obviously it is very aesthetic and well accepted by the patients. A disadvantage is that it also requires a special fabrication apparatus. Now let's look at the next group of retainers, which is the fixed retainers. Now the band and spur retainer has bands on a derotated teeth, and this band has spurs soldered onto the bands, and these spurs extend to the adjacent teeth. Now, it is indicated for the retention of a single tooth that has been derotated in a class 1 malocclusion situation. Now, the advantage is fairly conventional design and it enables good oral hygiene, but the disadvantage is it is unaesthetic because of the presence of the band. Okay, the next fixed retainer is the banded canine to canine retainer. So this is frequently used in the lower arch. It has bands placed on the canines and there's a wire contoured on the lingual surfaces of the anterior teeth, and the wire is soldered to the canine bands. Again, the disadvantage is it is unaesthetic. Now the next fixed retainer is the bonded canine to canine retainer. Now the wire is bonded on the palatal and lingual surfaces of all the anterior teeth. So there is a bond on not just on the canine, but the bond is on all the anterior teeth. Now it can be made, the wire can be made from stainless steel, plain blue alloy or a gold coated wires. Now the wire is adapted on the lingual surfaces. The terminal ends are curved and bonded on the canines. Now it prevents incisor recrowding and it holds the incisor in position. Now have a look at retention after certain types of treatment. Now let's look at rotations. Now derotations carry a high risk of relapse due to the resiliency of the gingival or supracrestal fibers. Now the one solution to this is to use a prolonged or long-term retention. As I mentioned earlier, the supracrestal gingival fibers take a long time, up to about 232 days to realign and reorganize. To help with this reorganization process, a procedure called circumferential supracrestal fibrotomy or precision can be carried out. In this procedure, a scalpel is used and the supracrestal fibers are severed. The aim of this procedure is that the severed fibers will quickly readapt to the new position, heal in the new position of the teeth. Now, after correction of class 2 malocclusion, headgear can be used where it was determined that the class 2 retention was due to a maxillary prognatism. So the headgear will be useful in retaining or restricting the maxillary growth until growth has stopped. Now, correction of midline diastema. A Hawley retainer can be used, or a fixed bonded retainer canine to canine, or in this case central to central, can be used to retain the correction. An adjunctive procedure that is useful or necessary is to do a phrenoplasty. Now this phrenoplasty will reposition the frenum in a superior position, and it will denude the alveolar bone and destroy the transseptal fibers, and it also allowed recontouring of the labial and palatal gingival papilla, and this is shown in the diagram here. Now, after correction of a deep bite, a removable retainer with an anterior bite plane is provided. So here we see an example of a modified Hawley with an anterior bite plane, and this can be useful to retain correction of the deep overbite. Okay, cleft palate cases also require a long time retention, and sometimes the retention has to be a lifetime retention. Okay, now adjunctive procedures to enable enhanced stability. Okay, one is a precision or precision, and the another procedure is a phrenoplasty. So both these have been mentioned in the earlier in the lecture. Okay, another adjunctive procedure is to do a surgical gingivoplasty. Now, usually at the extraction site, when the extraction site is closed, you may get bunching up of the gingival tissues, and this can contribute to relapse. So, to reduce the possibility of this happening, a gingivoplasty can be carried out to remove excess gingiva. Okay, but this has to go together with proper root paralleling of the adjacent teeth upon completion of the treatment. Another adjunctive procedure is called interproximal stripping or slenderizing the teeth. Now, this is it is believed that the mesiodistal to the buccolingual ratio, there's an ideal mesiodistal to buccolingual ratio for the lower teeth, and for the mandibular central incisor, it's 0.72, and for the mandibular lateral incisor is 0.95. Now, to ensure to enhance stability, to enhance this is done to enhance the stability, though it is not proven. Now, to carry out this procedure, a trial setup, Kessling setup is needed. Now, up to 0.2 millimeter can be removed from each surface of the teeth, and this will make the teeth slender. Now, the adverse effects of this procedure is the contact relationship is not normal, and too much removal of slenderizing of the teeth can cause the root to become close together. Now, active retainers. Now, active retainers are retainers which not active but allow some tooth movement to happen during the retention. Now, this is done because there might be a slight relapse in the retention period. Okay, for example, a Hawley can be used as an active retainer if the palatal acrylic is trimmed and the labial bow is activated to reduce a overjet. A wrap-around retainer similarly can have its bow activated to close band spaces. Now, band spaces occur mesial and distal to the first molars if the first molars have been banded during treatment. And a spring retainer can also allow for minor lower anterior segment realignment. Now, the stability of the lower incisors. Raleigh-Williams outlined 6 keys to ensure stability of the lower incisors. Now, he said that the lower incisor edge should be placed on the apogonian line or 1 millimeter in front of it. Now, the lower incisor root apices should be more distal compared to the crowns, and this applies to the lower canine root as well, and all the incisor apices must be in the same labiolingual plane, and the lower canine root apex should be more buccal than the crown, and lower incisors should be slenderized by flattening the contacts. This is because it is believed that a flat contact will hold the tooth in better alignment compared to a original rounded contacts. Now, duration of retention. Okay, there can be 4 duration of retention. One is no duration, whereby it is postulated that the correction is self-retentive. You have short-term retention, you have moderate, medium-term or moderate or prolonged retention, and you have permanent retention. Okay, now self-retentive or no retention, this is especially true in cases where this anterior crossbite has been corrected and an end of treatment and adequate overbite has been established. Now this overbite will be sufficient to retain the teeth in the corrected position. Okay, short-term retention. Short-term retention is usually 3 to 6 months full-time wear, followed by another 6 months night-time wear. Now, this is usually provided where the corrected anterior crossbite doesn't have a sufficient overbite to hold the teeth in the corrected position. Now, posterior crossbite, serial extraction cases, alignment of displaced teeth and alignment of buccal canines are the indications for short-term retention. Now, medium-term retention or prolonged retention, this is usually again 3 to 6 months full-time wear, but the nighttime or part-time wear is much longer, can be 1 up to 5 years wear. Okay, now this is done in usually in non-extraction class 1 cases where there has been arch expansion or proclination of the anterior teeth, and extraction cases class 1 and class 2, correction of deep overbite, correction of rotations, and correction of class 2 division 2 malocclusion. Permanent retention. Permanent retentions are usually provided with a fixed retainer or by using a prosthesis, for example in cleft cases. Now, this is done usually is quiet where the arch expansion has been carried out, especially mandibular arch expansion, and where there is generalized spacing due to arch length excess in comparison to tooth material, permanent retention will be required. Very severe rotations require permanent retention. Severe labiolingual malformations. Now, midline diastema in an otherwise normal occlusion will also require permanent retention once it's closed. Cleft palate cases and periodontally compromised dentitions. Okay, these are the references for this lecture. Thank you.